My name is Olivia Lee, and I am a faculty member at the UC Irvine School of Medicine, Gavin Herbert Eye Institute. Thank you all for joining us tonight. So we have a series of lectures for you tonight to cover ocular oncology from the front of the eye to the back of the eye, the eyelids, the orbit, everything. So I'm going to kick it off tonight by telling you about ocular surface tumors. So the outline for my lecture, we're going to first start by answering the question, what is an ocular surface tumor? And then I'm going to play a game with you, benign versus malignant tumors, explain how the diagnosis is made, and briefly touch on what treatments are available. So the term ocular surface simply means any of the structures of the eyeball or the eye that touch the tears and the air that doesn't include the eyelid skin. So that means the cornea, the conjunctiva, which is a very thin membrane in front of the white part of the eye and in front of the inner aspect of the eyelid. So I'll be talking to you about tumors that arise from this tissue here. And amongst the conjunctival tumors, there are benign tumors, there are pre-malignant or pre-cancerous tumors, and there are malignant or cancerous tumors. So I'll show you some examples of these. So if you look at this eye, it looks pretty normal. There's just maybe a little white lesion right here. And I'll tell you that this is the inner corner of the patient's right eye, where the nose would be on the right side of your screen. So this area gets a lot of sun. So does this area. But generally speaking, the under the upper eyelid, below, underneath the lower eyelid, you're protected from sun exposure there. So I'll outline it there for you that there is a very mildly elevated whitish lesion here, and we call that a pinguecula. That's a fancy term just to mean a benign tumor that is a slightly elevated growth of the normal conjunctiva, that is that thin membrane covering the white part of the eye. This is a very, very common growth for people to have. I bet most of you listening on the call today have one of these, whether you realize it or not. Some people can see it in the mirror. Some people, like this one, is relatively subtle, but we can see it easily because we're looking under high magnification. So if this grows, it can go past what we call the limbus or onto what looks like the colored part of the eye, meaning that tissue grew across onto the cornea. Here's a more prominent version of that where it's actually grown to cover the pupil. This is also a benign sun-induced lesion called a pterygium. That term means a wing-like growth onto the surface of the eye. So it's kind of this triangular shape. That word pterygium has the same Latin root as wing, as in pterodactyl or that winged dinosaur. So this is a benign lesion, and often it is called, in layman's terms, a surfer's eye. Uh, in Spanish, it is often said the lay term for that is carnosidad. Now, I'll compare that with this lesion, which is also arising from that same conjunctival tissue crossing across the limbus, and it is grown onto the cornea. However, this one is a cancerous lesion, and there are some subtle differences that I'll highlight later, but maybe from the patient's perspective, you could see both of these in the mirror, but you probably can't see in as great detail the structure and the shape of the lesion and the details of the blood vessels, as we can see here, because we're using high magnification. Now, this is an ocular surface tumor that is like a squamous cell carcinoma that you could get on the skin. And if we let this grow even larger, that's what you get. So this is the same tumor, just a much larger version. This type of tumor will grow locally, meaning it'll get bigger and bigger where it is. It can grow onto the eyelids, it can grow to the structures around the eye, but it wouldn't generally metastasize to some distant part of the body. So just to highlight again that this is the First one I showed you, which is a pinguecula, very benign, very common lesion. But even that, sometimes you see here, still looks very normal. Sometimes these can grow into an early tumor right there. So that blue arrow is showing you that these two lesions look very similar, but the red is showing you this area here is concerning. Similarly, we can have this benign pterygium, and it can have areas that will become like a cancer. And when I look at this, I see these blood vessels that are growing in this very straight direction. We call that straightening of the vessels, as if it's pointing in the direction of its growth. Whereas you can see here, the blood vessels, they don't have that straight appearance. It's more like it's coming out at you through the screen, and you're looking at the end of the blood vessel coming towards you. So what if it's a dark pigmented lesion? So these brown spots that you get on the eye, do you think that is more or less concerning? So it's not actually the color of it necessarily, but these are actually both benign lesions. These are called nevus, or plural would be nevi. These are like a little mole on your skin that you get, a little brown spot. And it is theoretically possible for it to become a cancer, but the overall risk of it becoming a cancer is very low, about 1%. The people are usually born with this, or they get these, notice these in the first decade of life. So when they're children, and they can grow, especially when the person is growing during growth spurts, puberty, or during pregnancy. That's normal. But in general, they don't really pose much of a risk. So we like to take photos of these, and that's why I have these photographs so that we can monitor for any change. Some people have these brown spots, and they're very flat, and they're not really changing. This is very common in people who have darker skin. I have one of these myself on my eye. In persons of color, I think this is very common and very normal. But if it were to arise all of a sudden in a adult, say middle-aged or elderly person who has very light skin, light eyes, light hair, any kind of new pigmentation like this is very concerning and should be biopsied. This is on the surface of the eye. Just for reference, the cornea is over here. The nose would be far off to the right side of your screen. So we would be concerned that this is a pre-malignant lesion that, if left alone, could eventually become a melanoma. And this is called primary acquired melanosis, whereas this one is called racial melanosis. This primary acquired melanosis has a risk to become melanoma and should be taken seriously. Any brown pigmentation that's new or hiding in an area like this is in the far inner corner of the eye, in a part of the eye called the caruncle, or this is under the upper eyelid. You don't even see it till we flip the eyelid backwards to look at the underside. This is melanoma. And here we see in some the primary acquired melanosis that I showed you before, this is a melanoma that's arising within it, and actually doesn't have very, very dark pigment. So any kind of new brown pigment, you shouldn't ignore that. This is one that we call a salmon patch. It has a smooth surface, and this orangey salmon color also needs to be biopsied. And this is not a sun-induced cancer. This is actually a lymphoma. Not every lesion we see on the conjunctiva is necessarily a tumor. This one actually turned out to be an infection. The patient had a prior surgery, and this growth appeared. And when we sent that for a biopsy, we realized that there was a infection there, and it went away with antibiotics. This, I thought, was a malignant tumor. I removed it, and actually it turned out to be an inflammatory lesion. Not every bump on the eye is a tumor. This is actually a cyst. It's a fluid-filled pocket There's nothing dangerous about it, but they can collect fluid underneath, so it almost looks like a balloon and can be very annoying. When the patient's blinking, they're feeling like something is moving around, but it's not dangerous. This is a benign tumor that sometimes we see in very young children or babies, and it's not that it's a cancer, but it is pressing on the eye, and you can see it's pressing on this part of the eye here, sort of almost indenting the uh, cornea here. So it's creating a pressure on that part of the eye that's inducing astigmatism. And usually this is inducing quite a bit of astigmatism. And that degree of astigmatism isn't easy to fix with glasses. Moreover, if it is a young child and they have a totally normal other eye, the severe astigmatism in the one eye could actually eventually lead to irreversible blindness. So we do like to remove those in young children. Now let's talk about how the diagnosis is made. Sometimes I simply look at the lesion and I just can tell by pattern recognition. I look at the blood vessels, I look at the size, there's ulceration, and I just know that it is a cancer because it's just so easily recognizable. Other times I use other clues to give me hints whether or not it is a cancer or not. So this rose Bengal staining might help. It's simply a pink dye that we apply to the surface of the eye like an eye drop. And I warn the patients that it looks magenta, bright pink, that they're going to walk out of the office and look at themselves in the mirror and think, what happened? Why am I bleeding? And I always tell them it's my fault. But if there's any pink that picks up on the lesion in question, that's very suspicious. So I'll bring you back to this photo I showed you earlier, and I said this part looks like a regular pinguecula. But when I put that rose Bengal staining on this part, there's some uptake of that pink stain there, so that makes this quite suspicious. This is another way we can aid in our diagnosis. This is a machine called an OCT. It's a fancy type of imaging camera that without touching the eye, without doing anything invasive, you just sit in front of the machine and it takes a special type of photo. We can see the cross section of this lesion without, it's almost like we can just cut it like this and then lay that on its side, and we're looking at the cross section of the tissue. So you can see here this hollow cystic cavity. It's like an empty hole inside the middle of this lesion. That means that there are cysts inside the lesion, very characteristic of a nevus. And remember what I said earlier, the nevus is benign and it's really nothing to worry about. So when we do this OCT to take a cross section, we see these cysts, we feel very reassured. On the other hand, this patient came in with this lesion here, and the OCT, the blue line is showing you where the cross section is taken. And you see this normal tissue is dark gray, but the tumor is a light gray and pretty thick. So that change in color and the change in the thickness from this very thin layer here to this thick layer here, that is a sign that it could be a cancer. And this did turn out to be a melanoma. But the gold standard is always histopathologic exam. What does that mean? It just means we take a biopsy, we take a piece of tissue, we send it to the pathologist. The pathologist is able to see that tissue with high magnification. They can see the individual cells in that piece of tissue, and we can identify the tumor cells. Furthermore, if we really do think that it is a cancer, there are special tests on the tissue that can be done to identify particular tumor markers and identify what kind of cell type the tumor is composed of. And this is really important because sometimes when we look at the lesion in our exam using a slit lamp microscope that every ophthalmologist and optometrist has, sometimes we just don't see the cancer. So these are two eyes of two different patients that came to our clinic and decided to have surgery for this benign appearing pterygium or surfer's eye. Most people elect to have this surgery for to improve the appearance of their eye or they feel irritated in this area, but it's generally not because we think there's cancer. And I am looking at these two photos right now, and I cannot tell you there's anything about it that looks suspicious. But one of these two, on the pathology, they found melanoma within this tumor. We were very, very surprised by this. And so now every single patient that I remove one of these pterygium, I always send it to the pathologist. And this has led me to do my own research and thinking about this condition. So let's talk about what treatment is available. Before we delve into treatment for cancerous lesions, I just want to point out that most of these lesions I'm talking about today, they come from sun exposure. So we think of there's more sun exposure in areas that are closer to the equator. Well, we're not as close to the equator as some of these other places. But in Southern California, we have a lot of sun. Maybe we're not so close to the equator, but the difference is we have a beautiful, nice temperature year long. It's easy to stay outside every day of the year here in Southern California. So I think we are getting a lot of sun exposure, even though we're not so close to the tropics. Please, please wear sunglasses when you're out in the sun. You can wear sunscreen on your skin, you can wear a hat, but you can't wear sunscreen to cover your eyes. So please wear sun protection when you're outside. So the treatment options for these, for a benign lesion is simple observation. Sometimes we just take photographs and refer back to those photographs, protecting your eyes from the sun. And sometimes we just remove them in surgery, either because the patient doesn't like the appearance or to make sure that it is benign. As I showed you earlier, we always send those for a pathologist to take a look at it under the microscope to be 100% sure that in fact it is benign. How about the malignant or cancerous lesions? When the lesion is small, confined to the surface of the eye, and not so large that it's overtaking the whole eyeball, we usually can do either medical treatment in the form of chemotherapy eye drops or surgery, which means excisional biopsy. What that means is it's not simply a biopsy, just taking a little piece of the lesion. We actually take the whole thing, and the eye is small. So we actually take the whole thing plus about 2 to 3 millimeters around. And that ends up being quite a lot because, as you know, the eye is very small to begin with. When I'm very suspicious that I'm dealing with a cancer, I will also do a freezing treatment at the time of surgery. Now, for very advanced disease, perhaps multiple recurrences, or it has spread beyond just the surface of the eye, we may consider radiation or even systemic therapy. And long-term follow-up, the benign tumors just need simple routine monitoring. If it's really something very, very benign, even a routine annual exam that you'd be getting for your eyes would be fine. But any patient with a malignant tumor, even after it's been treated and you're cancer-free, for a lifetime, you need to monitor for recurrence. And depending on what treatment you had, you may need to monitor for side effects of that treatment. For example, radiation to the eye does cause some side effects to other parts of the eye. So I'll just wrap up with some take-home messages that a variety of growths on the surface of the eye can occur. Not all of them are cancerous. Some of them are precancerous, some of them are not cancerous at all. An eye exam done by an eye doctor can detect and often diagnose these tumors. Sometimes we detect them simply by looking. Protecting your eyes from sunlight is very important in preventing these tumors, and the treatment should be personalized for each patient based on the diagnosis, the size of the tumor, and the extent of the tumor spread. I'm happy to pass the baton to my colleague and friend, Dr. Mishra, and he's going to move to the back of the eye and tell you about tumors we're going to move from the front of the eye to the back of the eye.
Great. Thank you so much, Dr. Lee, for that fantastic presentation. And as she mentioned, I'm Kapil Mishra. I'm one of the ocular oncologists here, and I also specialize in retina. And so I get to discuss cancer in the back of the eye, and we'll learn from the presentation that, these growths can happen anywhere on any part of the eye, but we have great treatment for all of it. So we'll go ahead and continue. So no financial disclosures relevant to this talk. And so, kind of looking at if we step back and before going into the different specific tumors, if we think about these fields of oncology and ophthalmology, oncology is such a large space, and ophthalmology, we're pretty specialized. And, although we think of ophthalmology as, encompassing a large world, there's so much more medicine outside of our field, but there is a little bit of overlap between the two. And this is really what we call ocular oncology. And that's why I'm sure Dr. Lee and Dr. Ediriwickrema can agree that it's very exciting to be an ocular oncologist because we collaborate so often with specialists in other specialties, especially oncologists, radiation oncologists, radiologists, pathologists, and any other part of the body that may spread to the eye. And so it's an exciting field. So ocular oncology is a comprehensive care of cancerous, precancerous, and simulating conditions in or around the eye. And so we take any tumor or any growth in or around the eye very seriously. And there are many conditions that are non-cancerous that can look like it. And so often, me and my colleagues, Dr. Lee and Dr. Ediriwickrema, are involved in cases in which the referring provider is not sure if this could be a tumor or not. And so we see a lot of different pathology that's not cancerous. And so it really does span all specialties in ophthalmology. As we said, the cancer can happen in the front part of the eye, inside, in the back part, and around of it. And it really is a limited number of fully trained specialists for this care, which is why, I love being at UC Irvine because I'm just right down the hall from other specialists, and we can collaborate and really put our heads together especially for challenging cases. So, in terms of the paradigm of ocular oncology, it's a little bit different than what we think of for the rest of ophthalmology, where in ophthalmology, vision is the most important thing, and we do a lot, deservedly so, to preserve as much vision as possible. But in ocular oncology, the perspective changes, and we sort of step back, and really anything we do, life is the most important thing. And so, whatever treatment we do is to make sure that we preserve life. And then after that, if we can, then we try and preserve the eye or the globe itself. And then only then after life and eye are satisfied, then we can focus on vision outcomes. And this is sort of a big picture approach to it, but any sort of oncology field takes this into account where you think of life in general over a specific organ. And so, as I've mentioned, Dr. Lee has mentioned, is that there can be growths everywhere in the eye. I mean, this is why we have so many subspecialties of the eye itself, because it's such a complex organ. So much processing power in the brain is based on vision, and there's so many different components of the eye, which is why in order to really provide the best care and provide the best outcomes, there are subspecialists within every component of the eye. And so eye cancer, unfortunately, is everywhere, but we have such great imaging modalities and such great examination techniques, which I'll get into. But this is a slide on the left where it shows possible growths on the surface of the eye, as Dr. Lee had shown. This is inside the eye on the iris, which I'll get to a little bit. This is kind of in the front part of one of the layers of the back part of the eye. This is all the way in the back of the eye. And then this growth is outside the eye, which Dr. Ediriwickrema will get into. And so, unfortunately, eye cancers do not discriminate. We see it in all ages, from a newborn to an elderly patient, all ethnicities, all parts of the eye, and it may involve the rest of the body. So we take this very seriously. So looking at some of the most common cancers by age, retinoblastoma we see in childhood, which is usually a white fluffy mass. Often a child may have a white reflex. So if you take a picture of a child, instead of having that red reflex that we see with flash from a camera, they may notice more of a white reflex, and pediatricians are excellent at being able to pick this up. And so this is the most common cancer in a child inside the eye. Young adults, conjunctival tumors that Dr. Lee got into. And then not so young adults, there are melanomas and lymphomas and all sorts of benign tumors or growths that can happen inside the eye. And so we'll talk about a little bit of these. So this is a picture of a melanoma, which I'll discuss, but this is a choroidal melanoma that we can diagnose clinically based on how it looks. And so in the back of the eye, if we tune our attention to the right part of the screen, there are all these layers in the back part of the eye. So there's the retina, which is, think of it like the film in the camera. It's a very thin layer in the back part of the eye that senses the light. And that's where the cones and the rods are. And underneath that is called the choroid. So in terms of the retina, we can get lymphoma, we can get benign growths, we can get metastatic lesions from the rest of the body. And the choroid is a very vascularized or has a very significant vessel network underneath the retina. And that's where we can get some of the more common growths in the back of the eye, and that's melanoma. You could have a nevus, which is not cancerous, which is very common, or you can get a metastatic tumor. So if you have breast cancer or lung cancer, it can spread through the body, through the blood, and end up in the choroid. And that's how we would see it in the back of the eye. And so, putting things into perspective, fortunately, these growths, especially the cancerous ones in the back of the eye, are pretty rare. This kind of puts things into perspective compared to cutaneous or skin melanoma, where that has, about an incidence of 14 per million per year. Whereas uveal melanoma is much less. We probably have about 2,500 cases in the US per year. And then conjunctival melanoma is even more rare, which is what Dr. Lee was discussing before. So the numbers are low. This is a very populous area, so we see a lot of patients, but the chances of getting uveal melanoma and conjunctival melanoma are very low. And so, kind of looking into the numbers, uh, people in the audience, or they may have friends or family in which a eye doctor looked into the eye and said, like, oh, you have a mole or you have a nevus. And this is extremely common. One of the studies showed that this was maybe in 8% of the US population, but a lot of specialists, including myself, think that this is underreported based on how those studies were conducted. And it could be even as high as 15 to 20%. We're not born with the choroidal nevus, so it does tend to happen at some point in our life, either in our 20s or 30s. And so many patients that I've seen have said, oh, I've had this for about 30 years or 40 years. And so it's not concerning, but it is something that we follow because it can transform into a melanoma. Each year, there's a 1 in 9,000 risk. It's low, it's very rare, but it is still worth following. So whether you see a retina specialist or a specialist like myself, or a general ophthalmologist or optometrist, it's worth someone dilating your eyes and taking a look and just ensuring that it's not growing. So as I mentioned, there are about 2,400, 2,500 new cases of choroidal melanoma each year. And interestingly, about a third of them are diagnosed as a small melanoma. So that is a great opportunity to be able to treat this and lower the chance of the melanoma spreading to the rest of the body. So this is a clinical picture of choroidal melanoma. It's the most common primary intraocular tumor. So the most common tumor inside the eye is actually a metastases from cancer elsewhere in the body. But the most common primary intraocular malignancy, meaning that it started in the eye, is a choroidal melanoma. As I mentioned, we get about 2,500 new cases per year in the country. It tends to be in patients, in older white patients. There seems to be a risk of Northern European ancestry, not as strong of a risk of significant sun exposure. So it's a little bit debatable on sun exposure, but usually having lighter eyes, like blue eyes, being of Northern European ancestry, that is more of a risk. But again, all of this is rare. So all this really means is just that everyone should get a dilated eye exam. We take this very seriously because choroidal melanoma can spread to the rest of the body in about 50% of cases. And I am impressed with the general oncology field, really, even in the last 10 years, with such amazing treatments on the market that has chipped away at this morbid percentage. And I think there's a lot of great treatments in the pipeline and even FDA approved treatments for metastatic choroidal melanoma that have come out in the last few years. So how do we detect these tumors? This is by routine examination by your local eye doctor. It does not need to be a specialist. It can be your general eye doctor, general optometrist. They dilate your eyes, or they take a photo and they see kind of a brownish, dark brown, or sometimes a lighter coloration of the retina, and we call that a nevus. And if they ever suspect a melanoma or they think that it's a little suspicious in some way, it's always great to refer to an ocular oncologist, just like myself. So one of my favorite parts of the job is that we take a lot of photos because each photo provides some valuable information and we compile all of it together to really clinch the diagnosis. So this is a choroidal melanoma down below in the retina, and we can take all of these different photos to really show, because there are many things that can grow in the eye, and we want to be as certain as possible. And every single type of tumor has a different morphology inside of it. And so that's the beauty of ophthalmology, is that we get an in vivo or a real-time look inside the eye and how the organ is behaving, and with all sorts of different photos. So when you come to our eye appointments, our appointments are long because you're kind of going through this assembly line of different photos, ultrasounds, and it's not many specialties in which you're getting your X-ray and your blood work and everything done at the appointment. And so that's the beauty, I think, of this field, is that there's just so much information just down the hall from us at our fingertips. And so this is a case that was described in the literature that I really like, that kind of showcases the advantage of having all these different imaging modalities. On the top panel here, this is a nevus near the optic nerve. So the optic nerve is the fiber optic cable that connects the eye to the brain. And just to the side of it, there's this coloration right here. And we can actually take a cross section through the retina and we can see all the different layers. And it's supposed to not be elevated like this. So it looks like there's a bump to it. And that's because there's this nevus here. We can take a different type of photo that shows us a little different morphology to it, as well as an ultrasound. So we put a probe onto the eye and that gives us some characteristic of how it looks. This patient was followed because it's unclear at this moment whether or not it's a nevus, which can look very much like this, or a melanoma. And sure enough, after being followed for some time, it did exhibit some growth. It's still considered a small choroidal melanoma, but because it's gotten thicker, this is where we would call this a choroidal melanoma and we would treat it. So, observation is the key in growths in which they're smaller, and if it does grow, which you can see in this case, the lesion did grow, we would categorize this as a choroidal melanoma and we would treat it. So I want to switch gears a little bit to talk about the most common intraocular tumor, and then we'll wrap this up with treatment for any of these lesions. Intraocular metastases is really important. We've known about it for a very, very long time. It's thought to be the most common intraocular tumor, and the incidence is even higher because many of these are asymptomatic. So patients are unaware that there is a spread to their eyes, and because it's not affecting their vision. And there is actually a sizable portion of patients in which it precedes the diagnosis of systemic cancer. So I have seen patients in which I found a growth in their eye and it looked very suspicious for a metastatic lesion, and they underwent a workup and a CT scan, and it indicated that there was an underlying tumor elsewhere. So these lesions reach the intraocular structures through blood. It most commonly develops in the uveal tract. So the uveal tract is the layer underneath the retina, which I called the choroid, as well as some of the front components of the eye. And this happens about 90% of the time in the back part of the eye, but it can grow in the iris as well, which we can see very easily on a clinical examination. So I wanted to just show this picture. This is a patient that I saw in training. This was a 34-year-old who presented to the emergency department with pain and decreased vision of the right eye. And this right here is a iris metastatic lesion that came from the breast. So this lady unfortunately had breast cancer, which spread to the front part of the eye. This is the same patient in the same eye. There's this little orange or creamy yellow, depending on the true colors of the photograph, that show a growth in the back part of the eye, which was consistent with a metastatic breast cancer lesion. So choroidal metastases, they cause blurry vision because they often tend to be near the center part of the vision, but in 1/4 of the time, it may not cause any blurry vision. So, it's always prudent that for patients who have a malignancy to get an eye exam at some point, especially if they have symptoms. But there's a proportion of patients who have no symptoms at all, which is worth being examined. In terms of origins of where these come from, 2/3 of them we know about an underlying malignancy, and that most commonly comes from breast cancer and lung cancer. But we've seen these lesions come from really any part of the body. And 1/3 of these lesions, there's no known underlying malignancy, which means that it's very important if we do find something that we can start investigating and start treatment earlier than would have otherwise happened. So how do we treat all of these lesions? So if I kind of lump these all into different buckets for choroidal melanoma, for metastatic lesions, for benign lesions, sometimes observation is appropriate if it's not convincing that this is metastatic or if it's a malignant lesion. We can do a lot of local treatments with laser. We can do radiation treatment, and that can either be done with the radiation oncologist where they do an external beam radiotherapy, or we can do a plaque brachytherapy, which I'll get to in just a moment. We can take a little sample of the tumor and then send it to our pathology colleagues to see what the composition is. And then in cases in which the tumor is very large and there's no vision and it's hard, there's a risk of it spreading to the rest of the body, then we would have the discussion of removing the eye because, as I mentioned at the beginning, life is the most important, and then the eye, and then vision. And so I want to end with one thing that we are offering at UCI is a plaque brachytherapy that we've now built this program in which it's the placement of a radioactive source on the eye surface. So it's a very small, the size of a nickel, in which we can custom design it with a third party company so that it fits perfectly to be able to treat a melanoma or a cancerous lesion in the back part of the eye. What we do is that during the surgery, we place this on the surface of the eye and we suture it or sew it into place. And then the patient goes home, stays in place for about 5 to 7 days, and then it comes out, or the patient comes back, and then we remove it a week later. And so this is just a schematic showing that, rough drawing. This is a choroidal melanoma, and we really put the plaque just right there to minimize the radiation affecting other ocular structures or elsewhere. And then this is a radioactive source that emits radioactive to the tumor, and then the tumor shrinks in size. And so that's an overview of the back part of the eye. It's a whole field in itself. There's so many lesions that can grow that are benign and malignant, and we offer all of that at UCI. But really the thing to stress is that a lot of these lesions you don't see in the mirror because it requires a dilated exam. So just make sure that you're getting with your general eye doctor or optometrist a dilated fundus exam or a dilated exam at least once a year. Well, I'll go ahead and pass it off to my esteemed colleague, Dr. Lilangi Ediriwickrema. The floor is yours.
Hi, everyone. Let me just pull up my talk here. Thank you, Dr. Lee, and thank you, Dr. Mishra, for this very comprehensive review intraocular in regards to intraocular malignancies. I'm going to kind of mix it up here and talk about periocular malignancies. And feel free to interrupt, ask questions as we go along. This can be, very, very natural. So I have no disclosures. I'll first sort of go over some of the more common cutaneous malignancies, ranging from basal cell carcinoma to squamous cell, melanoma, and then some of the more rare conditions such as sebaceous cell and Merkel cell. Then I'll emphasize really how we approach managing them, ranging from surgery, radiation, and really an emphasis on molecular targeted therapy, as there's been an explosion in terms of how we can really take care of our patients, especially with recalcitrant or advanced disease. So this is sort of a nice schematic of different patients who have various lesions that all turned out to be various forms of cancer. And so take a moment, take a look and at each of these figures and see, do you spot what's kind of off? Where do you think the cancer could be? So this is the first one. This is a basal cell. This turned out to be a melanoma, as did this one. Here we have a very advanced squamous cell, and this was a Merkel. And so when you take a look at these different types of cancers as they manifest, they all sort of have some things in common. So there can be changes in size and color, but there's usually distortion of the skin architecture. If it's right along the eyelid margin, you can have matarosis and changes in the eyelid position and the arrangement of the eyelashes. So taken together, that and feeder vessels or telangiectasia really should really make yourself concerned, is there something wrong, as well as your physician. Um, when thinking about the different types of cancers, I do want to take a pause and think about sebaceous cell and Merkel cell by themselves, as they tend to be rare, as well as two that tend to masquerade as other types of lesions, especially sebaceous cell in particular. So sebaceous cell can actually look like chalasia that don't go away, and they recur at the same location over and over, and can really look like a lot of different types of things along the eyelid margin. So given persistence and discharge, I believe one of the panel members had brought that up earlier, really should make you concerned for a malignancy or just something untoward. Merkel cell, in comparison, tends to be violaceous and can grow quite rapidly. And here are some representative photographs. When thinking about the more common malignancies, basal cell, squamous cell, and melanoma, they tend to all affect individuals of lighter skin complexion, so the Fitzpatrick 1s and 2s, individuals that have had sun exposure, so in people who spend a lot of time, on boats or out on and lifeguarding or as a surfer can really build a cumulative sun exposure that increases the risk of lifelong cancer development along the periocular and anywhere on sun-exposed areas. Individuals that are immunosuppressed or have other infections or smokers are also at increased risk. In terms of treatment, for basal cells, it has a largely favorable prognosis. Surgical excision is really done, usually leads to a favorable outcome as long as there's no deeply invasive component to the disease. Squamous cell also tends to do fairly well with excision. However, if there's orbital invasion or perineural spread, this is spread along nerves that can herald poor outcomes. And squamous cell can actually live a little bit dormant and then continue on and infiltrate deeper, even if you have gotten the cutaneous portion or the skin portion under control. So it's always important to be mindful. Is there numbness in the area? Are you developing double vision, for example, and things like that? In terms of melanoma, thickness is really important, as that directly correlates with outcome, and individuals with metastases on presentation have poor overall prognosis. In terms of sebaceous cell, there is an increased correlation with individuals of increased age and Asian descent, those who have metastases on presentation similarly have poor outcomes. In terms of Merkel cell carcinoma, they can manifest in fair skin individuals who have been immunosuppressed, and typically you do proceed with surgery in addition to central lymph node biopsies. So management strategies really, comes down to surgery when that's not really possible, particularly when we're talking about important skin. This is the eyelid skin that protects the eye, and so it's really prime real estate. And so if it's possible to even shrink the tumor, and then you're more likely to get surgical excision that's definitive, you can proceed with neoadjuvant immunotherapy. For those that are pretty extensive and infiltrative, exoneration with lid-sparing techniques to exist, and there's also potential for radiation. And when thinking about lymph node biopsies as an aside, that's something to consider in patients with thicker melanoma and Merkel cell. And for radiation, there's some patients with comorbidities, and then given the extent of disease, you may want to consider radiation for those patients. So really the emphasis of this talk is to consider targeted agents. And this is, as I mentioned earlier, really just redefine how we manage patients with cancer in general, but definitely periocular malignancies. So first, we'll begin with melanoma, and medications that have really just taken over. So these checkpoint inhibitors, we had the program Death-1, PD-1 checkpoint inhibitor, nivolumab and pembrolizumab, as well as ipilimumab, which is a CTLA-4 checkpoint inhibitor. And they really just hijack the immune system and take advantage of that process that cancer cells do. And by mirroring that, we are able to dampen the response and have a favorable outcome. And very recently, we've had this identification of the lymphocyte activation gene 3, LAG3 checkpoint inhibitors that in patients that are progressing with recalcitrant melanoma can be given in combination therapy for favorable outcomes. Just in your back pocket, there's always something to consider proton beam therapy if the side effects of these medications are really are not doing well for the patient. In terms of squamous cell, if you asked several years ago, the go-to were these EGFR inhibitors, and they really work by preventing homodimerization of these, or really these proteins that live on the membrane of your cells and preventing them from speaking and causing sort of downstream effects within the cell. But again, these checkpoint inhibitors have really revolutionized how we manage squamous cell as well. And in particular, semolipumab and pembro, as well as ipi, have taken over and really replaced the EGF receptor inhibitors. In terms of basal cell carcinoma, vismodegib and sonitigib, which are sonic hedgehog pathway inhibitors, have really changed the landscape. As you can see on this figure on the bottom right, they truly have an impact in shrinking the tumor and causing decreased infiltration as it pertains to the periocular region. Really helps shrink the amount of eyelid that would typically need to be removed if they don't have a full response to vismodegib, for example. One thing to be aware of is that there is an increased risk of developing secondary cancers, specifically squamous cell, so surveillance is important. And those patients that don't do well with vismodegib and sonitigib can be placed on sepilimumab, which is that PD-1 and checkpoint inhibitor. And for Merkel cell, really the PD-1, PD-L1 checkpoint inhibitors have changed the landscape for these traditionally very poor prognosis cancers, specifically pembrolizumab and adalimumab. So these are nice figures that show the dramatic response to checkpoint inhibitors as we've seen in many patients. The first inset shows a response to squamous cell. The middle, you have a PET scan showing really decreased disease burden for basal cell. And the bottom one is a Merkel cell on the nasal tip. And this is a paper that we published that looked at an in-transit melanoma in the periocular region that responded really nicely to checkpoint inhibitor therapy. And we also show that favorable prognosis correlated with the development of poliosis. So the fact that the eyelashes changed color actually was a favorable outcome. And then finally, I have the VISORB trial here that really shows these dramatic changes. And as you can imagine, having tumors on your eyelid margin, really shrinking them to complete resolution, or at least to an area where you can resect and reconstruct there with flaps and grafts, really improved our armamentarium in managing these patients. One thing that's important to know is that these checkpoint inhibitors, while amazing, do cause a host of side effects, and some of them within the eye, including uveitis. So you can have photosensitivity, red eye pain, retinitis, episcleritis, as well as encephalitis. So those are things to be mindful of when on these medications. And then just really quickly, in terms of surgical resection, some things I consider when I approach our patients is really thinking about each of the areas in the face as aesthetic units and working within the units if it's possible, and if not, the neighboring sites to bring in flaps and possibly grafts. It's important to have, blood control, to have underlying structural support, closure to really prevent, to maximize healing and prevent pain, and infection. So reconstruction, really, it's where we put the eyelid margin together. We can use the canthus, which is a corner of the eye, as a powerful fulcrum to recruit adjacent tissue and rotate that in. We have the option of borrowing the upper or lower eyelid, which has cartilaginous support to reconstruct larger eyelid defects, as well as full face and brow and various other flaps that can really help in reconstructing large defects, and can be quite extensive for what we need to do and can do. So a simple lesion like this basal cell can be in a ellipse versus our Merkel through a conjunctival approach, and here is a flat-based approach to the melanoma, and these are patients 3 months out, and they heal very nicely. So in summary, we have it's a really exciting time in terms of what we can offer our patients, and it's just really continuing to grow. And I think between tried and true surgical options, which really tend to be the gold standard, and then these options that we have for really advanced aggressive infiltrative disease, is very exciting.
Thank you all for attending, and hope to see you at our upcoming lectures. And thank you, Drs. Lee, Dr. Mishra, and Dr. Ediriwickrema for your time and a great lecture.